ऐसे कैसे बोल के वहां से चल नहीं सकती हो? काम होता जाएगा तुम्हारा। चलो जल्दी और शुरू लाइट ऑन करिए. ऑन कर सकते.
Very good afternoon to dear faculty members, colleagues and their residents. We are gathered here to commemorate World Ovarian Cancer Day. On this occasion, I take pleasure to say that today we are proudly carrying forward what we had started last year, that is Gynec Pathology Lecture Series. In this heading, we aim to teach and learn various aspects of Gynec Pathology, which we again started in the morning. We had a good lecture in the morning of around 2 hours on endometrial pathology. Today so in this lecture we'll be dealing with ovarian pathology and its clinical aspects. So with this background, I welcome again our brilliant speaker, Dr. Dept.of, who is a senior consultant in Department of Oncopathology, Tata Medical Center, Kolkata. She has been associated with Tata Medical Center, Kolkata since its inception. And she has been associated with Kidwai Cancer Institute and NIMHANS, Bangalore. She has a vast research experience and numerous national and international research publications in her areas of interest. She's playing an active role in coordinating and mentoring PDF oncopathology at her institute. She has also organized multiple subspecialty conferences, CMEs and workshops across India and abroad in her specialty. She is one of the founder member of Society of Genitourinary Pathologists of India and Gynec Pathology Society of India. Well, the words fall short to describe her achievements. I am grateful to Dr. Divya, who has kindly accepted our invitation for this CGR2. So I request Dr. Divya to please come on podium and enlighten us. She will be having an interactive discussion with the clinicians. The topic is what's new in ovarian pathology and its clinical implications. Welcome, ma'am.
A very good afternoon to all dignitaries and dear friends. At the outset, I would like to thank Department of Gynecology and Obstetrics and Department of Pathology, King George's Medical University, Lucknow, for having me here on this very wonderful occasion, the World Ovarian Cancer Day. As you all know, the World Ovarian Cancer Day is a global healthcare event commemorated every year on May 8th to raise awareness about ovarian cancer, stressing on its importance of early diagnosis and screening. And the theme for 2023 is No Woman Left Behind. Basically, this is an urgent call emphasizing the need to spread knowledge about ovarian cancer screening, ovarian cancer symptoms, and early diagnosis to every woman primarily residing in middle and underdeveloped countries. Now, with being a part of this endeavor and being a pathologist, I feel no woman left behind or no man and woman should be left behind in this audience to be abreast with the recent developments in ovarian cancer diagnosis. And with that, I get to my topic, what's new in ovarian cancer pathology, and in the next 40 to 50 minutes, I will discuss it along with its clinical implications. So going straight to the topic, the 5th edition of the WHO classification of tumors of female genital tumors was published in 2020. Although the classification of ovary and fallopian tube tumors remains rather unchanged, there are these fine epithelial tumors, non-serous epithelial tumors. Germ cell tumors more or less is the same as 2014, just a little expansion of the IHC markers. Now, if you've all seen the blue book, it's like a wedding album. So many pictures, so many colors, so many designs, so many patterns. So the ovary is characterized by the occurrence of a wide range of neoplasms, bewildering array of morphological features. But the good thing is what we discussed in the lecture in the morning, that most ovarian tumors are categorized by standard good morphological evaluation, and that's where the pathologist comes in. But there are significant problems which occur in the neoplasms of the same histogenetic origin. For example, sometimes differentiating an endometrioid from a serous, or we say endometrioid with some clear cell features, and it makes it sound like a higher grade. So these differences, endometrioid, serous, clear cell, can sometimes become difficult. Also, there are problems in distinguishing tumors of different histogenetic origins. You must have seen in your practice these Sertoli tumors or the granulosa cell tumors sometimes mimic endometrioid tumors. Remember, they are different histogenetic origins. Makes a huge difference to the clinician who's sitting right in front if you do not tell them what histogenetic origin it is. Another problem, the ovary is a common site of metastatic tumors. Sometimes there's no known primary, and this metastatic tumor can mimic a primary ovarian tumor, not only clinically, it can mimic it radiologically. Even when the tumor is out and grossly it is sitting on your grossing station, it can mimic a primary tumor, and a metastasis can also mimic a primary tumor microscopically. So, pathologists are faced with a differential diagnosis which is not readily or unequivocally sometimes, not always, resolved by standard histological examination. But what do we have in the recent years? There's been an explosion in the interest of the use of immunohistochemistry in surgical pathology. And I'm so proud to see KGMU having a wide array of IHCs in their armamentarium. I was just discussing with Dr. Shivanjali and Dr. Riddhi, 110 plus markers, and that is brilliant. That is absolutely brilliant. So, given the problems of ovarian tumor evaluation, the ovary has been a very fertile area for exploring the IHC ovary as elsewhere in gynecological pathology. The sentence by which Dr. Scully began this article in his own contribution was apt then, is apt now, and will forever be apt. He says, almost all ovarian tumors can be diagnosed on routine examination of adequate number of sections, good clinical history from your colleagues, and you can add a few special stains at his time in 1984, mucin, glycogen, argyrophil, and reticulin stain. And you can clearly see that what he said then is true now. Good clinical history, good HNE, and the reticulin stain, mind you, costs nothing, but it is invaluable in the diagnosis of sex-cord stromal tumors. And I will be showing you some examples. You may not have that molecular test in your lab, but if you have good HNE and good special stains, particularly reticulin when it comes to ovary, you can make a robust diagnosis. So don't overreact. When you see complex cases, look at the clinical history, look at the gross examination, look at the microscopy. And as Madam said, a very senior pathologist today during the lecture, she said, don't overuse or abuse IHC. But there has been tremendous work being done in the molecular alterations of ovarian neoplasms. And this integration is also important. We can't stay behind. We can't ignore it. So the integration of genetic information with your morphology, with your IHC in ovarian tumors is of great clinical significance to the clinician because it refines the diagnostic criteria. It provides prognostic stratification and prognostic implications. It comes with therapeutic implications, this genetic information. And of course, some of the tumors are associated with a hereditary predisposition syndrome. It gives you a chance for genetic counseling. So, though we have to know the basics, which is HNE, there is no substitute for that. IHC, yes, useful. Special stains, you need to get yourself abreast, updated with the molecular language because things are changing and you need to be the complete man or woman providing diagnostic criteria, giving prognostic implications and prognostic information, knowing therapeutic implications and also for the genetic counseling of these patients. So in the outline of this talk, I want this very brief. We will discuss the value of IHC in the differential diagnosis of malignant epithelial tumors. We will speak about sex-cord stromal tumors. We will speak about secondary tumors because they are important and have important clinical implications. Germ cell tumors, I'll just show you one slide because nothing much has changed. But I would like to specify on the molecular pathways and recent advances, which are primarily there in two classes: malignant epithelial tumors and sex-cord stromal tumors. And for the sake of postgraduates, I'm going to sprinkle in a few cases because at the end of the day, though I feel I'm a clinician myself, treating patients hand in hand with our clinical colleagues, I'd love to put some histopathology pictures, some biology colleagues and pathology juniors to enjoy. All right, so now coming to malignant epithelial tumors, we all know that the malignant epithelial tumors or the carcinomas are the most common ovarian cancers, accounting for 90%. So what comes to your microscopy table are the malignant epithelial carcinomas, isn't it? We don't see sex-cord and germ cell every day. But these carcinomas are not just a homogeneous group. They are a heterogeneous group of different diseases. Some, like low-grade serous carcinoma, follow a benign adenoma carcinoma morphology and a molecular pathway. They have a different pathway. Some, like the high-grade carcinomas, like the serous carcinomas, don't follow a benign adenoma borderline pathway. It feels like they came out of the blue, and they have a separate morphology and a molecular pathway. So this is the 2014 older blue book of the WHO, which tells you the main types. High-grade serous, most common, 70% what you see. Endometrioid, 10%. Clear cell, 10%. Primary mucinous ovarian carcinomas are not that common, they're 3% only. Low-grade serous carcinoma, not that common, less than 5%. And things like the Brenner's tumor, etc., very, very rare, hardly see those cases, they're less than 5%. Now come to the new WHO 2020. Again, as I said, it's a fatter book, thicker book. It's more bright and blue, and it's got some changes. It's got some newer subtypes, some of which I discussed in the endometrial lecture because they have similar endometrial correlates. Mesonephric-like adenocarcinoma, new subtype, undifferentiated carcinoma, dedifferentiated carcinoma, carcinosarcoma, and mixed carcinomas. So this has been refined further in the new WHO. There was this older entity called seromucinous carcinoma in the 4th edition. That has been removed in the 5th edition. So this was nothing but old wine in a new bottle. They tried to, everybody tries to show off and put in a new term. So seromucinous carcinoma was there in 2014. Basically, it was nothing but endometrioid carcinoma with mucinous differentiation. It was identical morphologically, the way it arose from endometriosis. So people realized that you can't fool us with new names. We sat, the consensus happened. They removed seromucinous carcinoma. Now they are called endometrioid carcinoma with mucinous differentiation. And I urge all of you to follow the recent classification so that you are on board with the clinicians who are also following the same classification and you all speak the same language. Now, as in 2014, it's now acceptable in 2020 that, and in 2023, of course, that high-grade serous and low-grade serous are fundamentally different tumor types and consequently different diseases. So in the context of the ovary, if you classify a tumor as just serous carcinoma, it has no meaning. You have to specify low-grade or high-grade. Why is that so? Now, low-grade serous carcinomas come from a precursor, of adenoma sequence, from a borderline tumor. They carry different mutations, KRAS and BRAF. They don't carry the deleterious P53 and BRCA abnormalities. Whereas the high-grade carcinomas, they come out of the blue. They don't follow an adenoma borderline sequence. They exhibit deleterious, dangerous P53 mutations, and some of them have the BRCA abnormalities, which has therapeutic implications. So please, in your report, don't say just serous carcinoma. Please try to specify in the ovary setting low-grade or high-grade serous carcinoma. So we know that low-grade and high-grade serous carcinoma differ in incidence. We saw that high-grade is more common, low-grade is less common. Pathogenesis I just showed you. Molecularly, they are different. The IHCs are different. The clinical features are different. The genetic risk is different. So high-grade is most common, 70%. They show a papillary and a solid growth. High-grade, very pleomorphic. They show a lot of anisonucleosis, very mitotically active. And everybody knows, anyone knows, even the clinician knows, very ugly tumor. And this is a high-grade serous carcinoma. What is the IHC profile? We are positive for PAX8. PAX8 is a Mullerian marker. So whenever a clinician sees PAX8, oh, chalo, ye ovary hai, kahin aur se nahi aaya. Isn't it? It's not a met. It's a great, how do you say, it's like hot chocolate. You get that and you know you're in the ovary. This tumor is WT1 positive. The ovarian serous are WT1 positive. P16 is diffuse block-like. And we spoke about P16 in the morning. In the setting of a serous carcinoma, P16 is not your HPV P16. That's the HPV P16. In this setting, it's the tumor suppressor pathway. So it is the P16 of that sense. So P16 is diffuse block-like in a high-grade serous carcinoma. And most importantly, P53 is mutated in all high-grade serous carcinomas. And this is a deleterious mutation. How does it look to you in the IHC? We discussed that in the morning too. The cells look strong, diffuse staining, strongly. Every cell, practically all cells, more than 80% are strongly and diffusely positive. This is a P53 mutation. Lo and behold, you saw it on IHC. So instead of seeing it molecularly, you saw it at the protein level and you're able to tell your clinician that this has got it is a P53 mutated tumor. Or your P53 can be 0. Null. That is also a P53 phenotype. And I will discuss some rarer forms with you. Of course, this is a very high-grade tumor. It's got a very high Ki67 index. What's the origin of the tumor? a lot of recent work has shown, starting from 2014, this is not new, this is in the business for long, this arose from the fallopian tube, the fimbrial end of the fallopian tube. And this is called, the origin is called serous tubal intraepithelial carcinoma, which arises in the distal fimbriated end of the fallopian tube. And this is there in the lining epithelium. Morphologically and IHC-wise, it's identical to a high-grade serous. It shows a p53 mutation and it's very ugly looking, but limited to the lining. Less commonly, they arise from the tubal-type epithelium on the ovarian surface or from ovarian inclusion cysts. So this is a picture to show you the normal fallopian tubal epithelium in the first arrow. It's a pseudostratified ciliated epithelium. Go down and you can see the p53. It's a wild-type staining. So normal epithelium does not show p53, it's a wild staining. Now, during the course of carcinogenesis, small foci of apparently normal, so to the naked eye, they are normal epithelium. If you see in the top picture, it is normal, but they develop p53 staining or a p53 expression. This is called the p53 signature. Further mutations on that, I mean, it's an early event, then develops into a stick. And stick can be seen at the HNE level, so it looks abnormal, but it's limited to the mucosa. And the p53, as you can see, is strongly and diffusely positive, it is mutated. And then, in the course of pathogenesis, it develops into an invasive serous carcinoma. So for us pathologists, we can't be doing p53 on all tubes and finding out signatures. That's not our job. Our job is to pick up stick. And for that, so this is the p53 signature, normal epithelium, but p53 abnormal, and this is the stick. So, because we know that the distal end of the fallopian tube is the origin of high-grade serous carcinomas of the ovary, there is a protocol for sectioning and extensively examining the fimbriated end of the fallopian tube, and this is called the C-FIM technique, in which you amputate and longitudinally section the distal end of the fallopian tube, which includes the infundibulum and the fimbrial segment. This shows maximum exposure of your tubal plicae, and you'll be able to pick up stick at the HNE level and then confirm it by doing a p53. And of course, the other, the ampulla and the isthmus are cut transversely. So how many of you here follow the C-FIM technique? This is for the JRs. If I'm allowed to ask questions here, am I allowed? Okay. How many follow the C-FIM technique when the tubes are normal? You don't do it when the tubes are abnormal. When the tubes are apparently normal in an extrauterine high-grade serous carcinoma, ovary has a serous carcinoma, do you put the tube entirely by the C-FIM technique? Okay, then you must. And also, you know that patients with the BRCA abnormality undergo prophylactic surgeries of the tube. Even in that case, this technique should be followed to pick up stick, all right? Which, because they have a potential of developing serous carcinoma. All right, this is another recent advance. It's an understanding of the primary site of serous carcinoma. If stick is present in a case of extrauterine, that means we're not talking about carcinomas of the uterus, so extrauterine serous carcinoma. If you're talking about, say, an ovarian serous carcinoma, but stick is present in the fallopian tube, what's your primary site? Fallopian tube, okay? These are the criteria for assigning a primary site. If you have mucosal involvement of the fallopian tube, but your bulk of the tumor is in the ovary, what's your primary site? It is again the fallopian tube. If you have a tubo-ovarian mass, means that the tube is incorporated within the ovary and you can't separate them clearly, what's your primary site? It's again the fallopian tube. Now, if you have an ovarian mass, you have completely put in the tube, no stick, no mucosal involvement, no tubo-ovarian, only then your primary site is ovary. Now, your ovaries are normal, your fallopian tubes are normal, we've completely put it in, there is no stick, there's no mucosal disease, but you have tumor in the peritoneum. Then it is primary peritoneal serous carcinoma, only then, which is a very rare event. And this diagnosis of primary serous carcinoma or primary high-grade serous carcinoma, you cannot make it in a post-chemotherapy setting, you do it in an upfront setting. Because it can happen that post-chemotherapy, the disease has gone away from the tube and the ovary. So this is something you make only in a pre-chemotherapy setting. Now, Everything is getting smaller and smaller. Phones are getting smaller, chips are getting smaller. The tissue is also getting smaller. What is the primary biopsy that you sometimes receive? Ascitic fluid. You make a cell block and you work on that. Omental biopsy, peritoneal biopsy, pleural fluid, and you see high-grade serous carcinoma in that. Do you want to do tubal, ovarian, etc.? No, you just call it, as far as you're ruling out endometrium, which you do, I'll tell you how, you just call it tubo-ovarian. So on a small biopsy sample, you're okay to call it tubal/ovarian or tubo-ovarian, okay? So we've studied that p53 mutations are present in all high-grade serous carcinomas, and 15%, however, have germline mutations in BRCA1 and BRCA2. p53 is the early event. If at all the patient has a BRCA abnormality, which occurs in 15%, occurs after the p53 mutations. So women with germline mutations in BRCA1 or BRCA2 have a 30 to 70% risk of developing ovarian cancer by the age of 70, and that's mainly high-grade serous. So the homologous recombination deficiency tumors, these are the ones which lack the ability to repair the double-stranded DNA breaks and therefore the tumor. Now, 1% also has germline mutations in other homologous recombination genes, and this is good for the JR3s, RAD51C and D. So HR deficiency or HRR testing, this is a common question which comes in the recent advances. So 1% have germline mutations in RAD51 and PRIP1, and a smaller percentage have somatic mutations rather than germline mutations. Now, high-grade serous, more than 95% have extra ovarian disease at the time of presentation. The median survival is 15 to 55. Stage and degree of debulking are the most important prognostic factors, and the surgeon plays a huge role in this one. The initial response after initial platinum-based chemotherapy is quite high, to the tune of 65%, but most patients recur after platinum-based chemotherapy. Those that are platinum sensitive, that is recurrence more than 6 months, have a favorable prognosis, and those that are platinum resistant, that is recurrence less than 6 months, have an unfavorable prognosis. So this was a paper which was published, which studied the chemotherapy response score post 3 to 4 cycles of NACT or neoadjuvant chemotherapy in high-grade ovarian serous carcinoma stage 3C and 4. And this was 11 countries, 16 sites, and from India, my center, and Dr. Radhika Srinivasan from PGI Chandigarh, we took part in this study. And we found that this is CRS1 post-chemotherapy, where there was minimal response. CRS2 had an appreciable response, and CRS3 had a near-complete response. So CRS3, we found in the study, was significantly associated with improved survival and compared to CRS1 and 2. So this validation of CRS in a real-world setting demonstrates that it is a robust and reproducible biomarker, and this can be incorporated in the therapeutic decision-making and the clinical trial design. So now coming back to BRCA, so what if the patient has BRCA germline mutations? These patients of high-grade serous carcinoma, which is actually a bad disease, but if they have BRCA1, BRCA2, they have a better prognosis, and they can be treated with drugs like PARP inhibitors, olaparib, rucaparib, and as maintenance therapy after the standard chemotherapy. It improves the PFS in BRCA1, BRCA2 carriers and women with homologous recombination deficiency. So this is a recent advance in high-grade serous carcinoma, where patients with BRCA1, BRCA2 have potential to be treated, and that is why, besides knowing your IHC and your HNE, you need to be updated with the molecular alterations in ovarian cancer. So let's just intersperse it with a few cases. 53-year-old female, left supraclavicular lymph node biopsy. But look at the history, it comes with a history, which is great. Patient has bilateral adnexal masses. And from the core, as I told you, tissue gets smaller and smaller, right? You get this very blue tumor, and this is how it looks. It looks like a carcinoma. It's malignant. It's metastatic. It's not a lymphoma. We all know that. There is anisonucleosis. What do you want to rule out first? There is a bilateral adnexal masses. We're in the ovary zone now. You want to rule out ovary, right? So first marker, which everyone loves, everyone has, PAX8, strong, Ovarian. So you know, chalo, I don't have to do more. Don't start with CK7, CK20 in this setting. This is just for pathologists. The gynecologists may get bored. But you know you have PAX8. Just put it in. It's PAX8 positive. I told you, WT1, strong diffuse positive. P16, this is the block P16 I was talking about, not an HPV surrogate, tumor suppressor pathway. Every cell is positive. This is called block positivity. P53, every cell is positive in this section. This is an overexpression, P53 mutated. You don't have to send it to molecular. You guys have P53 and that's wonderful. You told the patient now metastasis from a high-grade serous carcinoma, and you are opening the gates for further evaluation and further treatment of this patient. So this is the paper as I showed in the morning in the endometrium lecture. So the P53 mutation can be picked up on IHC. There are 4 patterns. The most common ones you cannot forget: the overexpression strong pattern, the 0 when none of the cells are positive, the null pattern. There's a cytoplasmic pattern, and very rarely there's a truncated mutation where the patient has a mutation, but it's showing wild on the IHC. Remember, IHC is a protein expression of a molecular change. Sometimes the molecular change can be a little subdued, and therefore it's not expressing at the protein level. So this is the wild type, which you can see is all labeled so that I don't have to use a pointer. The mutated overexpression type, where every cell is positive. The null type, what you see in the background, the brown, is the internal control. Okay, and the blue is not taken any staining. This is the null mutated type, and you have a rare one that's just for pathologists, a mutated cytoplasmic type. Okay, so 4 types. It's nice to put it into your report because the gynecologists read a lot, and they would sometimes, my gynecologist also calls me up and says, oh, mutated likha, overexpression ki null, and I say very smart, and then we put it in. So it's nice to educate each other, and they want to know too. So, next case, omental biopsy, 62-year-old female. Anybody has a doubt on this one? It's malignant. It's looking high grade. We discussed, doesn't look endometrioid or anything. Looks very ugly. This is a picture from the endometrial look. Same picture. I just show this because it's so well taken. It shows the pleomorphism, the mitosis, and the real dirty tumor. Don't call this just serous carcinoma. You have to say in the ovary setting, you have to go into low grade, high grade. But this is morphologically high grade. Pack says strong, you're in the O. So you're somewhere in the Mullerian tract. I don't know, ovary or what. You're in the gynecological tract. P53, what do you want to say now? Can you see it properly? Oh, it's not actually. What you can see in the background is the internal control. There is some blush. The tumor is actually negative. Okay, it's not taken up. It's not negative. It's a null type staining. It is mutated of the null type. Don't forget that, okay? What about WT1? I just showed you that serous carcinomas are WT1 positive. What is the WT1 here? Negative. So this was an omental biopsy. What do you want to tell your gynecologist? WT1 negative. Any further information? Do you want to help your gynecologist? She'll be very, very happy if you do that. WT1, excellent. We did that in the morning. This is just a revision. Negative wild type or WT1 favors an endometrial primary. In this case, it's a metastatic endometrium. It's gone beyond the pelvis into the abdominal cavity. This patient is metastatic endometrium. But if this was WT1 positive, it could be ovary and tube. Is it metastatic? No, it's stage 3, because that's not end disease. So when you say things like, use the words metastatic, you have to use it in the context of staging. Omental involvement in ovary is not metastatic. Omental involvement in endometrium is metastatic. So this is metastatic high-grade, metastatic serous carcinoma, endometrial origin. You should ask your gynecologist to do an endometrial aspiration biopsy, and lo and behold, even if all a hysteroscopy where they can maybe see a polyp, they'll take it out, it has a serous carcinoma. So that's how you help your clinical colleagues. Next case, 40-year-old female left an axil mass. What can you see? I can't even ask questions because of want of time. There are samoma bodies. You can see that. It's a very monomorphic tumor. Do you find it as ugly as the previous tumor? Even the clinician will say it looks kind of pretty. And lady gynecologists always know. They wear lovely saris like how madam is wearing today. They know what's pretty, what's not pretty. So they'll say, oh, this is a very pretty looking monotonous tumor. Again, you don't see the angry tumor over here. It's a very lovely, uniform looking cells, samoma bodies. This is again was WT1 positive. P53. Now would someone want to say about something about P53? What is this P53? Is it strong diffuse? Yes or no? No. Is it null? Is it there in some cells, weak in some cells, strong, patchy? Heterogeneous, you agree with that? So what is the P53? It's of the wild type. So with this biopsy, what do you want to say about the serous carcinoma? Do you just want to leave it as serous carcinoma, or what do you want to say? Low grade, excellent. So this is a low grade serous carcinoma, and this diagnosis makes a whole lot of difference to the patient. They are very uncommon, less than 5%. They come with a sequence, adenoma, borderline sequence. They are positive for PAX8, that's not going to help you. They are positive for WT1, that's not going to help you. What will help you is the morphology. They are not high grade, they are boring looking tumors, they are not pleomorphic, they have more samoma bodies than a high grade. Most important, they are P53 wild, and that makes a whole lot of difference. I don't use Ki67 to distinguish low grade versus high grade. I use morphology and P53 INC. Because the mutation is totally different from a high grade, KRAS, BRAF, NRAS. They don't show P53 at all. They don't show BRCA1 germline mutations. BRAF ones show high stage tumors. KRAS ones are associated with tumor recurrence. Right. Prognosis. If there are small foci of low grade serous in the borderline tumor, excellent prognosis. As the stage becomes more advanced, they fare less favorably. They keep recurring, that's the problem. But they follow a relatively indolent course. But the problem is they keep recurring in many situations. Now, how do you treat these patients? Primary surgical cytoreduction and no viable residual disease is the most important prognostic factor. Take out everything as much as possible and the patient will do very well. Can you give them NACT? No, they don't respond. So high-grade serous can be given NACT in many situations, but low-grade serous, they are not given NACT. So you have to be very careful when you're making the diagnosis, particularly on small biopsies like your omental biopsy, on your ascitic fluid cell block. Don't just say serous carcinoma and leave it. Please specify it's high-grade or low-grade. Now, the good news is that low-grade serous carcinoma express ER and PR, and therefore the gynecologist, when they recur, or the medical oncologist, treat it with endocrine therapy. And they also can be given a drug called the MEK inhibitor, trametinib, and this should show efficacy over chemotherapy and endocrine therapy. So your diagnosis has significant prognostic and treatment implications. Now, endometrioid carcinomas, I'm just going to rush, they're not that common, 10%. In a bacteriotic cyst, they are graded like the endometrial tumors. They look like endometrial, and we saw a lot of those examples in the afternoon. And the term seromucinous carcinoma has been removed from the WHO 5th edition. They are nothing but endometrioid carcinomas with mucinous differentiation. Like the normal endometrium are positive for ER and PR, they're negative for WT1, they're negative for NAPSIN-A, don't show P16, and P53 is of the wild type unless they are high-grade endometrioid, which can show P53 mutation. Now, how will you, it's important, as I said in the beginning, to distinguish endometrioid from some other tumors. If you wanted to distinguish it from high-grade serous, particularly if you had a high-grade endometrioid, you can use WT1 and P53 and an MMR IHC, as I specified. This can distinguish an endometrioid from a serous carcinoma. For distinction with low-grade serous, you can use a WT1. For distinction with clear cell carcinoma, morphology is enough, but in difficult cases, you can use a NAPSIN and a PR. Mucinous carcinomas can sometimes look like endometrioid. Mucinous carcinomas are ER/PR negative, endometrioid is ER/PR positive. Endometrioid can sometimes look like your GI colorectal metastasis. They very closely mimic. Remember, your GI tumors will be PAX8 negative, CK7 negative, your colorectal will be CK20 positive and SAT2 positive. So this is where you should use ISCs in difficult cases and not in every case. For sex cord stromal tumors, certain Sertoli tumors, adult granulosa cell tumors can mimic sex cord stromal tumors. Please use CK7, EMA, inhibin, newer markers, SF1, FOXL2, which I'll be talking about. Now, endometrioid carcinomas are associated with CTNNB1, PIK3CA, ARID1 mutations, and these are commonly encountered in patients of Lynch and HNPCC. There's also, just like there has been so much attention on the molecular subtypes of endometrial cancer, this is something new, not come in the WHO, so I won't spend time. People are working on the molecular classification of endometrioid carcinomas of the ovary, but we have some, it's not there as yet. Now, the stage of endometrioid carcinoma, they're mostly at stage 1, and coming to the next one, which is your clear cell carcinomas. They also account for 10%. These tumors are rarely bilateral. Endometrioid and clear cell both arise in the background of endometriosis and endometriotic cysts. And when they're associated with endometriosis, they have a favorable thing. Now, coming to the clear cell carcinomas, they morphologically can be picked up. They're very beautiful looking tumors, as you've seen earlier. They're pleomorphic, but in a very nice and a pretty way. They have complex papillae, basement membrane material, hyaline bodies, and there are less mitosis. If you compare this with a serous carcinoma, serous looks ugly. Clear cell carcinomas don't look as ugly. They have lesser mitosis, but yet they have these typical micropapillary, tubulopapillary structures with hyaline bodies, hobnailing, and hyalinized cores. If you wanted to distinguish this, it can be done on morphology, but on IHC, they are positive for PAX8, NAPSIN-A, HNF1 beta. They are negative for ER/PR and WT1. If you use WT1, NAPSIN, and you can distinguish it from us, and NAPSIN A and PR are used to distinguish it from endometrioid carcinoma. So this is a 69-year-old female pelvic mass biopsy. What does it look like on morphology? It looks like tubules with monomorphic cells. They're not like an endometrioid glands. They are more rounded nuclei. They don't look very aggressive like a serous. Here you can see some more tubules and some clear cells and some hobnailing. PAX8 positive, NAPSIN positive, ER/PR negative. What's your diagnosis? Clear cell carcinoma. So endometriosis, as I said, is found in 50 to 75% of clear cell carcinomas, and some of them also have loss of function mutations in ARID1A, PIK3CA mutations. So they're very much like endometrioid carcinomas. And stage is the most important prognostically, and most cases are limited to the ovary if you go stage 1 and stage 2. Coming to this important mucinous carcinoma. So 10 to 15% of all primary ovarian tumors are mucinous tumors, and the majority are benign. The malignant primary ovarian mucinous tumors are very few. So which tumor am I actually afraid of in the ovary? I will say it is when it becomes mucinous, because I have to know my clinics, I have to know my radiology, I have to see at the time of frozen section, I have to be standing like this, I have to know my tumor markers, I have to see morphology and not get swayed by the morphology. This is where I use IHC, and I use it. I don't care about the money, because a huge difference, metastatic versus primary ovarian. Metastatic does not need surgery. You need to give it chemotherapy. A primary ovarian mucinous needs staging surgery. So much of cost to the patient, so much of morbidity to the patient if you make the wrong diagnosis. So if metastasis to the ovary, particularly the GI tract, is excluded, if you exclude the mets, only 3 to 4% of ovarian cancers are primary ovarian mucinous. So this is where I sweat the most. So the vast majority, but look mucinous, they have a gastrointestinal, gastric pyloric, gastrointestinal differentiation. They look very much like coming from the colorectum of the intestine. We don't know the origin of these mucinous tumors. The primary ovarian are large, more than 13 centimeters. They are unilateral. If they are bilateral and smaller than 13 centimeters, they say it's metastasis. But do ovaries read books? Do tumors read books? They don't. So all sorts of combinations and permutations occur. You need to be very aware clinically, radiologically, grossly, microscopically, and immunohistochemically. All right. So mucinous carcinomas, good news is they arise again in a sequence, adenoma, borderline, invasive. So that's how they occur. But the bad news is that some pancreatic tumors, appendiceal tumor primaries, they'll metastasize to the ovary and they will mimic a borderline tumor. This is called maturation effect. They try to differentiate into go in the reverse direction. It's called anti-aging or something. That happens. So you need to be super aware, and that's when ILC plays a massive role. Now, once mucinous carcinomas are identified, you have to tell the gynecologist important things. What is the pattern of invasion? Is it a confluent pattern of invasion? Is it an infiltrative pattern of invasion? And this is a very, very important concept, and it's a lecture in its own. I will just show you some standard pictures. Confluent means back to back. complex, labyrinthine, just like stuck to each other. This is a confluent pattern of invasion. Infiltrative is when it just infiltrates with desmoplasia, the stroma reacting up. So that's an infiltrative pattern. Obviously, with the sound of it itself, confluent sounds like a better prognosis. Infiltrative sounds infiltrative and sounds dirty. It's got a bad prognosis. What is the treatment implication? I didn't show it for other tumors, but for mucinous, I'm showing you. Stage 1 tumors, if you say confluent primary ovarian, mucinous ovarian cancer, confluent type, may not get chemotherapy. But if you say infiltrative, it gets chemotherapy, may or may not get chemotherapy. So these two, this is an advancement in our understanding and refinement in our understanding of the confluent versus infiltrative pattern of invasion in mucinous carcinomas. Problem with IHC, this is a really difficult area, and that's why I sweat. Primary ovarian mucinous carcinomas can be Paxate negative. So where you were nicely drinking your hot chocolate and saying, oh, I'm in the ovary, here you may be in the ovary and you don't know it. It may be coming out of the ovary and you still don't know it, because Pax8, in my experience, is positive only in 20-30% cases and will be focally, and that's where I love to use the word focal, because I'm really looking for that focal to be able to say that it is ovarian. CK7 is more positive than CK20 in a primary ovarian setting. CDX2 is an intestinal marker, won't help you, it's positive here. P53 is of the wild type, very rarely mutated. P16 lacks block positivity. It's negative for ER. The minute it comes positive for ER, it's endometrioid with mucinous and not primary mucinous. It's negative for SATB2 because if SATB2 comes, it's intestinal. It's negative for P16 or lacks block positive for P16 because if it is, it's coming from the cervix. So you have to be very careful in this differential. Now, just a clinical thing, when you see a case on your sign out, ask yourself a question, is this tumor bilateral? Yes, likely metastatic. No, is the tumor less than 13 or more than 13 centimeters? Yes. Think it could be metastatic if it's less than 30. No, it's likely primary, but that's not where you stop. This is just your brain starting to think. These are the markers that you must have or must do or must outsource if you don't have. CK7, CK20, CDX2 and Pax8. Pax8 comes positive, throw a party. It's at least it's Mullerian, but do a P16 to rule out endocervical. Pax8 comes negative. You have to do CK7, CK20 and CDX2. In that situation, you have to do additional markers to rule out pancreatic origin, a SMAD4 loss, P16 endocervical origin, SATB2 colorectal, upper GI origin, and then after everything is negative, take into account unilaterality, bilaterality, less than 30, more than 30. Another good news is if you get strong CK20 and strong SATB2, it is likely of appendiceal or colorectal origin, unless, what's the caveat in this? It can still be a primary ovarian mucinous if it's arising from the GI epithelium of a teratoma. You know a teratoma? It can have GI colorectal epithelium. That can give rise to an adenocarcinoma, which will be like a colorectal. That's the only exception. So keep that in mind. Okay. So quickly, this is a 60-year-old female right in nexal mass. There are two lesions in this. One on this side, one on the other side. This one looks a little transitional like epithelium, isn't it? What is this? Brenner's. Okay. On the other side is a more infiltrative, mitotically active tumor, which was CK7 positive, Pax8 negative, GATA positive, P63 positive. Postgraduates, what's the diagnosis? Malignant Brenner's tumor, very rare, I just got it for you. They resemble an invasive urothelial carcinoma, but you can't make a diagnosis unless you see a benign Brenner's on the side. They comprise less than 5%. I see 1 in 2-3 years, and it's very, very uncommon. I'm going to skip that. But this is a chart which is very useful because it makes us think like clinicians. Please keep in mind, and I said this in the morning and I repeat myself now, you are a pathologist, you are behind the microscope, your clinician is facing the patient. If you start thinking like your clinician, you will be a more useful person, and believe me, you will walk side by side with them. So if it is a high-grade serous carcinoma, we've studied that they have P53 mutations, BRCA1 abnormalities can also be seen, and therefore, the clinician can give it PARP inhibitors and immune checkpoint inhibitors. A low-grade serous carcinoma has KRAS, BRAF, and it can be given MEK inhibitors, endocrine therapy, etc. Clear cell endometrioid carcinoma syndrome. So these can be subject to genetic testing and counseling. And clear cell can be given tyrosine kinase inhibitors in the recurrent state, and endometrioid can be given mTOR inhibitors. Mucinous carcinomas have KRAS and they have HER2 amplifications, and when they recur in the advanced stages, you can treat them with trastuzumab. So you need to know the molecular advancements in ovarian epithelial tumors to be able to guide treatment, prognostication, and even genetic counseling. So quickly, 639-year-old female right adnexal mass. It is showing a blue tumor like you saw in the morning. It's a cystic tumor with lot of glands, papillae, retiform structures, and colloid-like material within the lumen. What is the diagnosis? Just on morphology. Quickly. Yes, mesonephric-like adenocarcinoma. These are associated, it's a new subtype, and there in the WHO 2020, they are associated with endometriosis, as you can see in this picture. Their GATA3 IFC profile, they are negative for ERPR, negative for WT1, lacks block positivity for P16, P53 wild. This is a new kid on the block, mesonephric-like. Why are they called mesonephric-like? They arise from the remnants or the rests of the mesonephric, which are there in the para-ovarian tissue. So para-ovarian, as Sir mentioned in the morning, they can be there in the fallopian tube or in the para-ovarian structures. From there they arise, then they are called mesonephric adenocarcinoma. When they arise within the ovary, you don't have mesonephric remnants within the ovary. They are called mesonephric-like adenocarcinoma. And it's a rare tumor. Pathogenesis is unclear. They arise from Mullerian carcinoma, which has undergone mesonephric transdifferentiation, or they arise from true mesonephric remnants in the para-ovarian area. And they need to be differentiated from endometrioid carcinoma and high-grade serous because of treatment implications of high-grade serous, and also they are more aggressive than endometrioid carcinomas. Now coming to the dedifferentiated carcinomas, this is again just like your uterus, you have a well-diff component on one side and a very monotonous looking tumor on the other side. I will not go into that. You have carcinosarcomas, again a biphasic tumor of the ovary, just like the endometrium, quite rare. On the top you have the picture's much better here. You have the epithelial carcinoma on the top and the rhabdomyosarcomatous component at the bottom. Carcinoma plus sarcoma is equal to carcinosarcoma. Mixed carcinomas are something you don't call it just like that until and unless you see two different types on H&E confirmed by IHC, only then you call them mixed. The most common mixture in the ovary is clear cell plus endometrioid. And why is that? They both arise from endometriosis. And now with the recognition of the mesonephric-like, even these occur in a setting of endometriosis. So you can see many more. You can see clear cell plus serous plus mesonephric-like. Okay. Quickly about sex-cord stromal tumors, the reason why I'm talking here, though the classification remains unchanged, there has been tremendous work on the molecular pathways in sex-cord stromal tumors. New kid on the block is the gynecoblastoma, which was there earlier, removed in 2014, reintroduced in 2020. So, as I said, let us quickly look at it. What is the problem with sex-cord stromal tumors? Number one, we don't see them very often. What you don't see often, you find difficult because you want to open the book again and again. It's easy to diagnose when the classic form is there, but between the same types, adult granulosa, juvenile granulosa, all thecoma, fibroma, there's a lot of overlap between this type. IFC will tell you this is sex-cord stromal, and it will differentiate it from the malignant epithelial. IFC will not help you in saying this is adult, this is juvenile granulosa, this is thecoma. No. IFC will not distinguish the types of sex-cord stromal. They will identify a broad heading that this is sex-cord stromal. Okay. Older markers have always been there, inhibin, calretinin, I'm sure you use it. The new markers are SF1, steroidogenic factor 1, and FOXL2. And if you wanted to distinguish it from malignant epithelial tumors, the markers to use are EMA, CK7. And of course, you'll use SAL4 to distinguish it from germ cell tumors. So the importance lies here. two new markers, SF1, FOXL2, little difficult to validate. I'm still validating FOXL2, but excellent markers. These are positive in all sex-cord stromal tumors. But if you use this, you can't distinguish the types of sex-cord stromal tumors. But you can use them in the differential diagnosis for malignant epithelial and germ cell tumors. These are the two excellent papers which gives you an update on ovarian sex-cord stromal tumors by Orgulu. And this is by Dr. Raven, who had visited our hospital just a couple of months ago, and he'd given an excellent lecture on sex-cord stromal tumors. So what's new in the molecular landscape of sex-cord stromal tumors? These tumors, the adult granulosa cell tumor has a defining mutation called the FOXL2 mutation. Okay, so there is this FOXL2 mutation, which is a sensitive and a specific biomarker for adult granulosa cell tumor. This mutation is rarely found in thecoma, juvenile granulosa cell, etc. Now, what I want to tell you now quickly is FOXL2 IHC is picked up by all sex-cord stromal tumors, but only adult granulosa cell tumor has the FOXL2 mutation, and few Sertoli-Leydig cell tumors have the FOXL2 mutation. So mutation is not equal to IHC in this particular case, and I can repeat myself. FOXL2 mutation is seen in adult granulosa cell and not in juvenile granulosa cell and other tumors, but FOXL IHC is seen across the board in all sex-cord stromal tumors, and this is a very important concept. Okay. Now, why do you want to do FOXL2? Do you really need it in clinical practice? Sometimes you have a lot of difficulty in diagnosing a cellular fibroma from an adult granulosa cell tumor. Suppose I had that one stain to do to distinguish between the two. What would it be? I don't have the money to buy SF1 and FOXL2 and independent calretin. What would be that stain? It's a special stain, and that's called reticulin. It's the most powerful special stain, costs nothing in your laboratory and makes a whole lot of difference to the patient. Fibroma is a benign tumor, behaves in a benign fashion. Adult granulosa cell tumor is malignant. Patient can recur after many years. Suppose you do your reticulin and you know it's a very difficult stain to. That's when you can send your tissue for FOXL2 fibroma or a thecoma and will not be present. It will not be present in a fibroma or a thecoma, and that mutation will be present in an adult granulosa cell tumor. Okay, so reticulin around individual cells favors a fibroma or a thecoma. Consider a FOXL2 if your reticulin is indeterminate. Now, accurate diagnosis of adult granulosa cell is very important as it's a malignant disease and patient can have late recurrence, late metastasis, and they require a very long-term follow-up. You can't tell an adult granulosa cell tumor to go home and never come back. You have to keep calling them for a regular follow-up. All right. Now coming to the Dicer1 mutation. This is another new kid on the block. If you were to ask me what are the two updates in sex-cord stromal tumors, there are two. FOXL2 mutations in adult granulosa cell tumor and Dicer1 mutation in Sertoli-Leydig cell tumor. These are the two updates in the sex-cord stromal list. Now, the somatic Dicer mutations have been found in 60% of Sertoli-Leydig cell tumors. No Dicer has been found in adult granulosa cell tumor, and no ovarian sex-cord stromal tumor has both FOXL2 and Dicer mutation. They are mutually exclusive. Now, why is it important to know Dicer? Because germline Dicer has a hereditary predisposition of developing pleuropulmonary blastoma, a very aggressive thoracic tumor, cystic nephroma, multilobular goiter. It's a part of a syndrome and runs in families. And that's why Dicer1 mutation is very important in Sertoli-Leydig cell tumor, because it opens the door to further genetic counseling of the patient and the family. So on the basis of Dicer and FOXL2, there are three types of Sertoli-Leydig cell tumor. This is a recent advance. You have a Dicer mutant tumors, you have FOXL2 mutant Sertoli-Leydig cell tumor, and a Dicer FOXL2 wild. This you can go and read it up. My job was to enlist all the recent updates on this auspicious World Ovarian Cancer Day, and that's why I've done it. And it's important for the exam-going postgraduates to know the subtypes of the Sertoli-Leydig cell tumors. There's another tumor, a new kid on the block in WHO 2020 in the sex cord stromal tumors, microcystic stromal tumor. Now, why is it important? It looks like this. It's got microcysts. It stains with beta-catenin and cyclin D1. It's negative for inhibin and calretinine. Importance is, again, mutationally, they have CTNNB1 mutations in AP. What are these mutations? The FAP pathway. You all know the tumor pathway, and they can be an extracolonic manifestation of familial adenomatous polyposis. Again, this opens the door for further testing of these patients. So, though I again reiterate, morphology is very important. Of course, you can't begin without that. ISC is important, but you cannot ignore moleculars because the implications are huge. I'm going to skip this case. This was basically a gynandroblastoma with a juvenile granulosa cell and some Sertoli cell tumors. And this has been reintroduced in the WHO 2020. This case is a young female having almost a blue cell tumor, which was mimicking a juvenile granulosa cell. It had some rhabdoid areas. It was WT1 positive, CK18 positive, synaptopositive, EMA positive. I91 was retained, P53 was there and not there also. Basically, this is a small cell carcinoma of the hypercalcemic type, a very aggressive tumor seen in young females. And BRG1 is mutated in almost all the cases, and this has an IHC for that. Loss of BRG1 is the definition of small cell carcinoma of the hypercalcemic type. There is not much change in the germ cell tumors. These are very good reference articles if you wanted to read them in detail. Your dysgerminoma, yolk sac, embryonal are the same. SAL4 is a marker seen in all germ cell tumors. For dysgerminoma, you can use an OCT4, a CD117, and a plaque. For embryonal carcinoma, CD30, and for yolk sac tumor, AFP and Clipicam. Now, good to remember that almost all ovarian malignancies can be diagnosed with a high degree of reproducibility in routine practice with good clinical input and with good good HNE and with a good pair of eyes. If you have reticulin, it's a very valuable stain. It's not an IHC, it's a special stain, it costs nothing, and it's very invaluable in sex cord stromal tumors. Don't use one marker alone if you really have to use them. Use them in a panel because no antibody is specific. If you are using antibodies, use them in a panel. Don't use them in isolation. Now, my grandmother used to say that there are some things which never, ever go out of fashion. And this is actually what she used to say, and I got this on the internet. But she used to say, don't call people after 10 p.m. Don't interfere with things none of your business. So I agree, those good manners never go out of fashion. So good IHC, the time-honored IHC, the time-honored discussion with your clinical colleagues, thorough cross-examination, thorough sampling of your specimen, knowing basic things. What's your age of the patient? Young age, germ cell tumor. Older age, high-grade serous carcinomas. In the 30s, if you're looking at a serous carcinomas, think of serous before you jump to high-grade. Think of low-grade serous. Also know there's a history of endometriosis. I have to look for endometrioid and clear cells. So the time-honored things like good clinical sense shouldn't go out of practice just because you have IHC. But the grandmas are also becoming very smart, and they have decided that they need to move with time. So we do need to move with time and incorporate genetic information with morphological and immunohistochemical findings because we've made the diagnostic call, but we want to refine our diagnostic criteria. We've made the diagnostic call, but we need to prognosticate the tumor. We've made a diagnostic call, we have to do genetic counseling because of the predisposition syndromes I described. So in today's age, I think you have to do a personalized welcome to personalized medicine and move ahead with times. And on this occasion of the World Ovarian Cancer Day, the ovary is a fabulous area on which all this is being done. So early diagnosis, recognition of symptoms, early screening, good pathology practice will lead the clinician to a healthy and a happier patient. So thank you for the patient hearing. I overshot, I'm sorry.
No problem at all.
A very warm welcome to the people who joined a little late, but yes, I would
not like to miss out the names, Dr. Arun Chaturvedi sir, Amita Jan ma'am, and many more people who came by invitation. Thank you, Dr. Divya, for bringing the entire spectrum of ovarian tumors on a single platter. We are overwhelmed since the morning. We are having a lot of feast, academic feast. May I now request our head of the department, Professor U.S. Singh sir, and head of the department of Gynae and Obs, Professor Jaiswal ma'am. Now, welcome sir. We have the Pro Vice Chancellor sir also to present a memento and a certificate of appreciation to our guest speaker today, Dr. Divya Midha, who has come from Tata Memorial Center, Kolkata. Sir, please, on the dais. So now we hand over the mic to Department of Obstetrics and Gynecology to continue with the felicitation program. Dr. Shuchi, please. And thereafter we have a small rally for awareness regarding the ovarian cancer. So we all welcome all the survivors, the attendants, the staff members who have joined or kindly joined to accompany us in the rally. Thank you so much.
A very good evening to all. It's a moment of immense pleasure to welcome you all to World Ovarian Cancer Day celebration. And to begin with deep gratitude, I invite our dynamic Pro Vice Chancellor, Sir, respected Professor Vineet Sharma, Sir, to join on dais. Sir, we are humbled by your gracious presence. Welcome, Sir. Next, with deep regards, I invite Head of the Department of Pathology, Professor U.S. Singh, Sir, to place the dais. Welcome, Sir. Next, I courteously invite Head of the Department of Obstetrics and Gynecology, Professor S.P. Jaswal, ma'am, to join on the dais. Welcome, ma'am. Next, I delightfully call upon in charge of Genital Cancer Control Unit of Queen Mary's Hospital, Professor Nisha Singh, ma'am, to join on the dais. And I also request Professor Arun Chaturvedi, sir, to please join on the dais. A very warm welcome to all respected dignitaries. Next, I request Head of the Department of Obstetrics and Gynecology, Professor S.P. Jaswal, ma'am, to give a welcome address.
Thank you, Suchi. As we know, we are here to celebrate the World Ovarian Cancer Day. Not only day, this is the whole month which we are going to celebrate. And we have had a wonderful lecture by Dr. Divya. Really, you have delivered a wonderful talk. Although we are, as a gynecologist, we are not so fond of, don't know what, but definitely we could able to correlate something with some pictures. So really it was a very good talk. And on the behalf of Department of Obstetrics and Gynae, along with the behalf of Pathology, now I am welcoming all of you because you have come here to join us in this celebration. I first welcome our Pro Vice Chancellor, Dr. Vineet Sharma. Welcome, sir. You have taken out some time and graced this occasion. Definitely, I would like to welcome HOD Dr. USC and a very senior person, Dr. Arun Chaturvedi. We always remember whenever we feel problem in oncology, even in gynae oncology, we always call, sir, please come and help us. He's always ready to welcome. And I welcome to the other dignitaries or faculties from the other department, along with some survivors are here, our whole department is here, and our residents are here. I welcome you all on this day. Thank you so much.
Thank you, ma'am. Next, I invite Professor Nisha Singh ma'am to enlighten us and give us an overview of ovarian cancer and some message on this very important occasion of World Ovarian Cancer Day celebration.
A very good afternoon to our Pro Vice Chancellor, Professor Vineet Sharma sir, to Professor US Singh, HOD Pathology, Professor Arun Chaturvedi, very senior surgical oncology member who has been helping us, and Professor SP Jaiswal, HOD Department of Obstetrics and Gynecology, all the faculty of other departments, students, nurses, employees, and the patients, the survivors who have come, our guests, and each one of you present in this hall. I welcome you all to this program, which is a different kind of program. And as I'm speaking to the non-doctors also, so I'll speak in Hindi. ये जो कार्यक्रम आज हम लोगों ने किया है, वो खास तौर से जो ये विश्व ओवेरियन कैंसर दिवस, और जैसा मैडम ने बताया कि जो हमारी इंटरनेशनल सोसाइटी है, उन्होंने इस पूरे माह को ओवेरियन कैंसर माह घोषित किया है, और इसके बारे में जानकारी कम होती है लोगों को, इसीलिए हम लोगों ने इस कार्यक्रम को इस स्तर पर करने की कोशिश की और उनको बुलाने की कोशिश की जिनका इस कैंसर से इलाज हमारे यूनिवर्सिटी में हुआ है, हम सबकी मेहनत से और उनके भी सहयोग से, क्योंकि वो समय से आए, समय से इलाज कराया और आज वो हमारे साथ यहाँ पर उपस्थित हैं। थोड़ा सा ओवेरियन कैंसर के बारे में बताना चाहूँगी। महिलाओं में तो कैंसर होते हैं, उसमें से ब्रेस्ट कैंसर सबसे कॉमन है, स्तन कैंसर आप लोग जानते हैं, उसके बाद गर्भाशय ग्रीवा का कैंसर होता है, आंतों के कैंसर होते हैं, उसके बाद ओवेरियन कैंसर होता है। लेकिन खास तौर से इसके बारे में बात करना इसलिए जरूरी है कि ये अधिकतर बहुत एडवांस स्टेज में पता चलता है। 70% लोगों में एडवांस स्टेज में पता करता है और इसकी वजह से काफी लोग अपनी जान गंवा बैठते हैं क्योंकि समय से वो लोग दिखाते नहीं हैं। और भारत में भी अगर आप देखें तो काफी पेशेंट्स हैं। हम लोग जब परसेंटेज में बात करते हैं ना तो कम लगता है, लेकिन इंडिया की पॉपुलेशन इतनी है कि अगर 5% भी कहें तो वो बहुत सारे लोग होते हैं जिनको ये परेशानी होती है और उसी की वजह से इतने सारे लोग अपनी जान खो बैठते हैं। हमारे अस्पताल की अगर बात करें, लास्ट 5 साल का डेटा मैंने थोड़ा सा यहाँ दिखाया है। 2017 से 22 तक इंक्रीजिंग नंबर है जिन पेशेंट्स का हम लोग ट्रीटमेंट करते हैं ओवेरियन कैंसर के केसेस का। लास्ट कोविड में थोड़ा सा डाउन हुआ है, अदरवाइज 100 से ऊपर पेशेंट हमारे इसमें रहते हैं। हमारे यहाँ ऑपरेशन से इलाज होता है। ओवेरियन कैंसर ऐसी बीमारी है, सिर्फ एक बार ऑपरेशन करके काम खत्म नहीं होता। ऑपरेशन करते हैं, उसके बाद कीमोथेरेपी ज्यादातर को देनी पड़ती है, और जो कि करीब 6 साइकिल्स तक होती है। तो एक लंबे समय उनका हमसे एक संबंध बना रहता है मरीजों का। तो ऑपरेशन इस तरह से हुए हैं, और कीमोथेरेपी इतने मरीजों को, क्वीन मैरी में हम लोग अपने मरीजों को खुद कीमोथेरेपी देते हैं, और उसके बाद जहां हाई एंड कीमोथेरेपी 2nd लाइन 3rd लाइन चाहिए, वहां हम लोग मेडिकल ऑन्कोलॉजी डिपार्टमेंट से सहयोग लेते हैं और या फिर उनके पास रेफर करते हैं। अगर ये पिक्चर सिर्फ इसलिए मैंने डाला था कि गर्भाशय और अंडाशय में फर्क समझने के लिए, यूट्रस गर्भाशय है और अंडाशय दोनों तरफ होते हैं ओवरीज। दिस मार्कर डजंट एनीवेज। ओवेरियन कैंसर जब ओवरी तक सीमित रहता है तो अर्ली स्टेज होता है। अगर उस स्टेज में पता चल जाए तो ये बहुत अच्छे से ट्रीटेबल है। लेकिन अगर ये बढ़ जाता है और जो आसपास के अंग है, जैसे यूट्रस है या ब्लैडर है या बावल है, तो फिर और उसके बाद पूरे पेट में फैले तो फिर ट्रीटमेंट भी डिफिकल्ट होता है और उसका पूरी तरह से ठीक होने में भी मुश्किल होती है। बहुत वैरायटी के कैंसर्स होते हैं ओवरी में, क्योंकि ओवरी में कई तरह के कोशिकाएं होती हैं। इसलिए आप हमारे सर्वाइवर्स हैं 18 साल से लेकर 65 साल तक की उम्र के लोगों को अलग अलग तरह के ओवेरियन कैंसर होते हैं। तो कोई ये ना समझे कि ज्यादातर 60-70 उम्र में होते हैं, लेकिन ऐसा नहीं है कि उससे कम उम्र में नहीं हो सकते। तो ये कभी कोई ना सोचे कि क्योंकि हमको तो नहीं हो सकता। रिस्क फैक्टर क्या है, किनको ज्यादा रिस्क है? जिनके कम बच्चे हैं या बच्चे नहीं हैं, जिनको जल्दी पीरियड्स आना शुरू है और लेट मेनोपॉज हुआ, ओबेसिटी और स्पेशली यंग एज में ओबेसिटी, उन लोगों को ज्यादा रिस्क होता है, जो चाइल्डहुड ओबेसिटी हम लोग कहते हैं। कोई जो ईस्ट्रोजन रिप्लेसमेंट थेरेपी पर है, हार्मोन रिप्लेसमेंट चल रहा है, उनको भी रिस्क ज्यादा होता है। 10 से 15% को हेरिडिटरी ओवेरियन कैंसर होता है। कभी अपने परिवार में पूछ कर देखिए, अपनी माँ से, मौसी से, बहनों से या पिता की तरफ भी, कि किसी को ऐसा कोई कैंसर, ब्रेस्ट कैंसर या अंडाशय का कैंसर तो नहीं हुआ है। तो फिर उस केस में हमें कुछ स्पेशल टेस्ट करने होते हैं, और अगर हेरिडिटरी कैंसर निकलता है तो उसको बचाव के उपाय भी होते हैं। सिम्टम्स, अगर आपको ऐसे लक्षण हैं कि बहुत पेन हो रहा है या सूजन हो रही है या पेट फूल रहा है, खाना नहीं पचता है, कोई यूरिनरी प्रॉब्लम्स हो रही हैं और वो लगातार हैं, 6 महीना हो गया, साल भर हो गया, ठीक नहीं हो रहा, हमेशा मेडिसिन डिपार्टमेंट में जाएंगे, बेहतर है कि एक बार गायनी डिपार्टमेंट में भी दिखा लें। तो सोचें कि कुछ और भी हो सकता है अगर कोई चीज नहीं ट्रीट हो रही है। डिफिकल्टी अगर हो रही है खाने में, जल्दी पेट भर जाता है, ऐसी तकलीफों में दिखाना चाहिए। क्या हम इससे बच सकते हैं? बचने के लिए ऐसा नहीं है कि सबको कोई चीज हम कर दें और छू मंतर हो जाए, ऐसा नहीं है। लेकिन कुछ चीजें हैं, जैसे कि ओरल कॉन्ट्रासेप्टिव पिल्स, जो गर्भ निरोधक गोलियां जो लोग खाते हैं, उनको इसके कैंसर का खतरा कम होता है। दूसरी चीज, जिनको हेरिडिटरी कैंसर का अगर पता चला है तो उनमें हम लोग ट्यूब्स और ओवरीज ऑपरेशन करके निकाल देते हैं, तो उससे आगे वो खतरा होना खत्म हो जाता है। बस इसी के साथ समाप्त करूंगी कि हमारे यहाँ, हमारे डिपार्टमेंट ऑफ ऑब्स्टेट्रिक्स एंड गायनिकोलॉजी में सभी तरह की सुविधा है। हमारा एक हेरिडिटरी कैंसर क्लिनिक अभी कुछ दिनों पहले खुला है, जिसमें इस तरह की जानकारी दी जा सकती है, और ऑपरेशन, कीमोथेरेपी, सभी तरह की सुविधाएं हमारे यहाँ हैं। थैंक यू।
Thank you, ma'am. Next, we move on to most awaited moment of today's evening, felicitation of our ovarian cancer survivors, जिन्होंने अपने जज्बे हिम्मत से ओवरी के कैंसर को मात दी है और औरों के लिए मिसाल और प्रेरणा का स्रोत बनकर हम सबके बीच में आज उपस्थित हैं। I invite Dr. Bharti, our Gynae Onco Fellow, to give us a brief introduction of our stars of this evening.
Thank you, ma'am. Good afternoon to all. We have 7 ovarian cancer survivors with us today. They have rightly proven that you beat cancer by how you live, why you live, and in the manner in which you live. I'm happy to invite all of them in today's event and be a part of this program. Our first patient is Mrs. Deepa. She is 54 years old. She had surgery followed by chemotherapy in 2015. Her cancer is in remission and she is on regular follow-up now.
I humbly request our respected Pro Vice Chancellor Sir to kindly step forward to felicitate our brave warriors, our heroes who have defeated this deadly disease.
Our next patient is Mrs. Niklesh, 48 years old. She was treated in 2017. She had a recurrence last year, but she was treated and is on maintenance chemotherapy now. Our next patient is a young patient, Miss Sakshi. She is 18 years old. She was diagnosed and treated for dysgerminoma. She is doing perfectly fine and is on regular follow-up. Next patient is Mrs. Bindu, 56 years old. She was treated for ovarian cancer in 2017. She later developed breast cancer in 2021. She was tested for BRCA mutation and came out to be BRCA1 positive. She is on maintenance chemotherapy. Mrs. Mushrifa Khatun, 37 years old. She is our oldest follow-up patient. She was treated in 2012 with surgery and chemotherapy and is in remission now. Next patient is Mrs. Sanju, 48 years old. She was diagnosed and treated in 2016. She is doing well and her cancer has not returned after treatment. Our last patient is Mrs. Adesh Kumari, 31-year-old young woman. She was diagnosed with an ovarian mass during pregnancy. She came to us immediately after delivery and was successfully treated for germ cell tumor. She conceived spontaneously after the treatment and has delivered her baby in March 2023. Thank you.
Thank you, respected all, for doing the honors and salute to our brave cancer survivors. अब मैं मिसेस दीपा पांडे से अनुरोध करती हूँ कि वो मंच पर आकर संक्षिप्त में अपने कैंसर के सफर के बारे में कुछ कहें।
Respected doctors and all medical staff, आप सबको मेरी तरफ से नमस्ते। मुझे इसका जब डाउट हुआ तो मैंने इसका चेकअप कराया तो मेरे को एक डॉक्टर मतलब वो गायनिक नहीं थी लेकिन मुझे उनका पता नहीं था कि वो गायनिक नहीं है तो उन्होंने उसका जो है ट्रीटमेंट मेरा एक यूटीआई भी उसमें किया। फिर मैंने अल्ट्रासाउंड करवाया अपने मन से, उन्होंने तो नहीं कहा था। जब अल्ट्रासाउंड कराया तो उसमें एक बहुत बड़ी सिस्ट निकली तो मुझे डॉक्टर ने सजेस्ट किया कि आप जाइए क्वीन मैरी। यहाँ मुझे एक बिल्कुल भगवान स्वरूप मेरे एक डॉक्टर निशा सिंह, उनसे मेरा संपर्क हुआ तो उनके उसमें मेरा ट्रीटमेंट हुआ। लेकिन मैंने इसको नेगेटिव उसके नहीं लिया, मैंने इसको पॉजिटिव तरह से लिया कि मतलब मेरे को स्टार्टिंग में पता चल गया कि मेरा ठीक हो सकता है। तो मेरा ऑपरेशन हुआ 23 नवंबर 2016 में और मेरी कीमो स्टार्ट हुई दिसंबर 2016 से। तो उसके बाद भी इस हॉस्पिटल में जितने डॉक्टर्स, जितने नर्स, सबका ट्रीटमेंट मेरे साथ बहुत अच्छा रहा। और मुझे डॉक्टर को देख के ही, मेरी आधी बीमारी थी, मेरे को डॉक्टर निशा मैम को देख के ही ठीक हो जाती है। तो मैं इनको अब देखते से भगवान ही मानती हूँ, क्योंकि इनकी उससे मेरी बीमारी पूरी तरह ठीक हुई। और अभी मेरा फॉलोअप मेरे को 7 ईयर्स हो गए कंप्लीट। तो अब मैं बिल्कुल, मुझे कोई प्रॉब्लम नहीं है, मैं बिल्कुल ठीक हूँ। तो मैं तो बहुत अपने को समझती हूँ कि मैं इस हॉस्पिटल आई और डॉक्टर मैम से मेरा बहुत हुआ। थैंक यू।
धन्यवाद दीपा। अब मैं आग्रह करती हूँ मिसेस साक्षी मौर्य से, वो भी मंच पर आकर चंद शब्द कहें।
Good afternoon, everyone. Medical staff, dear doctors, professors. मैं ज़्यादा कुछ नहीं कहूँगी, बस इतना कहूँगी कि जब मुझे पता चला इसके बारे में तो मैं बहुत ज़्यादा डर गई थी। बट स्पेशली मेरे पेरेंट्स ने मुझसे ये चीज़ कही थी कि ट्यूमर नहीं है, बस स्टोन है, आपको चलना है, बस आपका ट्रीटमेंट हो जाएगा, आप वापस आ जाओगे। फिर डॉक्टर नाइक मिली, उन्होंने मुझे यहाँ रेफर किया, तब मुझे यहाँ पे निशा मैम मिली एंड मैं बहुत ज़्यादा इनके लिए थैंकफुल हूँ, क्योंकि मुझे आज भी याद है जब मेरी पहली कीमोथेरेपी थी तो उन्होंने मुझसे कहा था कि बेटा हम आपको अपना बच्चा समझ के ट्रीट कर रहे हैं। वो मोमेंट मेरे लिए सबसे अच्छा था और मैं इतनी ज्यादा श्योर हो गई थी, इतनी ज्यादा पॉजिटिव हो गई थी कि मैं ठीक हो सकती हूँ। एंड आई एम वेरी थैंकफुल टू हर कि उन्होंने मुझे अपना बच्चा समझ के ट्रीट किया एंड आज मैं आपके सामने हूँ, मैं बिल्कुल ठीक हूँ। आज मैं फॉलोअप के लिए आती हूँ और मैं बता नहीं सकती मैं कितनी खुश हूँ कि मैं वापस से अपनी नॉर्मल लाइफ में आ पाई। सो आई एम वेरी थैंकफुल टू मैम एंड all the staff members, doctors. Thank you everyone. Thank you so much.
धन्यवाद साक्षी। Next I request our Honorable Pro Vice Chancellor Sir to bless us with his words.
Thank you. On behalf of this university, I welcome you all to this celebrations on World Ovarian Cancer Day. As rightly mentioned, this is not only the day but the month that is being celebrated. And as Dr. Nisha told you, it's a treatable cancer provided you come in an early stage. So awareness is more important. And I'm sure this awareness will go on and on in this whole month. I also congratulate the Department of Pathology and Dr. Divya, who gave a very good lecture. Unfortunately, I missed it because I was somewhere else. Apart from the awareness and the lecture that was given, Dr. Nisha needs a special mention, as their survivors told a story of how empathy and sympathy Dr. Nisha has shown towards her patients. I congratulate her and the Department of Obs and Gynae for being so considerate for the patients that they need their services. In the end, I would like to only say that cancer is a sentence in which all of us get worried, the parents get worried, the patient himself is worried, but at the end of the day, if timely intervention is done, a sympathy and empathy shown by the doctors, probably this world will be a better place for them to live. Thank you much.
Thank you, sir, for your generous words. Now I request Head of the Department of Obstetrics and Gynecology, Professor S.P. felicitate Pro Vice Chancellor Sir with a memento as a token of our respect and gratitude. Next, I request request our Honorable Pro Vice Chancellor Sir to felicitate our Head of the Department of Pathology, Professor U.S. Singh Sir, with a memento as a token of our respect and gratitude. Next, I request our respected Pro Vice Chancellor Sir to felicitate Professor Arun Chaturvedi Sir with a memento as a token of our gratitude and respect. I also humbly request Sir to kindly felicitate our Head of the Department, Professor S.P. Jaswal Ma'am, with a memento as a token of our love and respect. I once again humbly request you, Sir, to please kindly felicitate Professor Nisha Singh Ma'am with a memento. Thank you, Sir, for doing the honors. Thank you, all respected dignitaries on the dais and off the dais, for giving your valuable time on occasion of this Ovarian Cancer Day celebration. Thank you for all your valuable presence. And now I request dignitaries on the dais to kindly flag off the rally of Ovarian Cancer Day and request all to join.
So there are some snack boxes outside. Please take the snack boxes and then move into the rally.